In the head trauma lecture, what you really need to be able to do is identify the mechanism of injury and link it to a diagnosis, and the CT scan and link it to a diagnosis, knowing that it's either going to be surgery or they're screwed in the way of management. So let's start off first with basilar skull fracture, something that might tell you from the outside that, hey, something more sinister could be on the inside. You should suspect a basilar skull fracture in someone who's got head trauma, and this guy's got 2 eyes, a nose, an ear, and a sad face because he's in trauma. You should suspect a basilar skull fracture if you have raccoon eyes, that is hematomas around the eyes, and generally it's around both if it's bad enough. Or someone who has battle sign, which is a hematoma behind their ear. You see either of those things, the head trauma was probably bad enough to cause some damage on the inside since it broke the skull. The other thing you can use to suspect it is if someone's got a lot of otorrhea or rhinorrhea. Clear otorrhea, clear rhinorrhea in the presentation of a trauma is not boogers, that's CSF. And if you get CSF leaking out, they need a CT scan. Basically, if you see basilar skull fracture symptoms, get a CT to make sure there's not something else more sinister underneath. One of those things that might be more sinister is the epidural hematoma. Epi above, dural the dura. What happens in an epidural is you get this massive trauma to the side of the head. Someone walks into a baseball bat or glides gently into a tree in a pair of skis. Underneath here is the brain. Right? The brain just doing what it's doing. But then this thing begins to bleed. The middle meningeal artery is the thing commonly tested and associated with epidural hematomas. And because it's epidural, what happens is that there's bleeding between the skull itself and the dura. And because of that, it's contained in this lens-shaped hematoma. Lens-shaped means epidural. The 2 concave sections are formed by the skull and the dura. And what happens is that then this pushes on the brain. Whenever you do imaging, what you care about is the response of the brain relative to midline. A shift past midline is a big problem and needs to be intervened on. Now, the way you're going to get this is someone's going to have trauma, and right after the trauma, they lose consciousness. But then they wake up, they have a lucid interval. And after that lucid interval, they die. They go back unconscious and they don't wake up again. The walk, talk, and die syndrome. This is why if someone has trauma hard enough to lose consciousness, they probably need a CT scan, especially if we're talking about side of the head or skiing injuries. You get a CT scan, and then having identified the hematoma, you drain it with a craniotomy. Neurosurgery puts a hole or removes the skull and allows the bleed to drain. Now the other dural is the subdural, and it comes in 2 forms. You're going to have an acute subdural hematoma or a chronic subdural hematoma. And the difference is not in the CT scan, but the difference is in the patient and the trauma. Acute subdurals happen in people who shouldn't have subdurals. This is going to be a young patient in the way of shaken baby syndrome, abuse of babies, or adolescents with Superman syndrome. Those teenagers that think they're invincible. So you're going to get a massive trauma, like 80 miles an hour car crash, patient ejected. They're going to come in with a loss of consciousness, and then they die. There's no lucid interval. What you're going to see on a CT scan is that brain. Only the bleeding happens between the dura and the brain. So you get a crescent-shaped hematoma. A crescent-shaped hematoma is a subdural. You identify it because they had a big trauma with loss of consciousness. They get a CT scan of the head. And the treatment, unfortunately, is more likely praying than anything else. But what you want to do is reduce intracranial pressure, and you can do that in a couple of ways. You can hyperventilate the patient after intubating them. You can elevate the head of the bed to 30 degrees, or you can try mannitol. This stuff works to decrease intracranial pressure, but very rarely does anything in the way of prognosis. The trauma was so bad, they're probably dying not from the hematoma itself, but from the impact on the parenchyma. Now, if you look at chronic subdurals, you're going to see somebody who's not young, but instead is either very elderly and demented, or someone who's drank away most of their parenchyma. The idea is that the veins in your brain are the same size. So if you've got a big robust brain that fills the skull, the veins don't have very far to go, so they're loose and don't have to worry about being torn. But as that brain atrophies away from the skull wall, those veins have to stretch out and become very fragile such that only minor trauma might shear them. So chronic subdurals are caused by old people or alcoholics who have shrunken brains, and they get a tearing or a shearing of the bridging veins. And this occurs in minor trauma like falls. The person has a trauma, and if you got a CT scan as soon as they fell, you'd see the crescent-shaped hematoma. But what happens subsequently is that slowly over time, the bleeding worsens. Now, it has time to compensate, so very rarely do these cause a crossing of midline, which is a neurosurgical emergency. Instead, what happens is these patients develop headaches, and that then leads to worsening in their cognitive function, which is one of the reasons why, when you work up dementia, you get a CT scan. You're not looking for the brain atrophy to confirm, yeah, they're demented. You're looking for something you can reverse, and one of that would be a chronic subdural hematoma. If you find it, you do a craniotomy or a burr hole and drain it. Of course, it should be obvious if someone has a brain bleed, by the way, you should attempt to correct their anticoagulation. So if they're on warfarin, have an elevated INR, you want to give them FFP. If they have thrombocytopenia, give them platelets. And it's also important to notice that as we discuss these brain bleeds, there's a very limited space in the skull. In fact, if you bleed any significant amount, you're going to push on the brain and cause seizures or focal neurologic deficits. It is an impossibility that someone exsanguinates into their brain because the skull is fixed. The abdomen is loose and floppy and has skin and muscles holding together. And while other areas might show expansion or hematomas, the brain doesn't. The skull is fixed, has a very small amount of volume in there, so any bleed is going to present as a focal neurologic deficit far sooner than it will be exsanguination in the way of hypotension. Two other head injuries that are not bleeds, so will not show up on CT scan, is going to be concussion and diffuse axonal injury. A concussion is almost always going to be in the setting of a sports injury. It doesn't have to be, but on the test it will be. What you'll see is a positive loss of consciousness and positive retrograde amnesia. They won't remember the play. They won't remember being tackled. They won't remember being hit in the head with the ball, but they'll remember setting up for the play, or they'll remember the pitcher throwing the ball. The diagnosis is going to be made by a normal CT scan. What happens in a concussion is the brain is in the skull, right? And the skull's around the brain, and the skull suddenly stops. The brain, sitting in fluid, continues to move forward and smashes into the front of the brain and then recoils and smashes into the back of the skull. And so you've got coup and contra-coup injuries. But they're not bad enough to cause any bleeding, so it's just parenchymal injury. If you got an MRI, you'd probably see some edema. But the MRI is not necessary. Because if someone comes in with a GCS of 15 and has a normal CT scan, they can go home and be observed, as long as there's someone there to observe them. What they're looking for is the inability to be aroused, nausea, vomiting, seizures, focal neurologic deficit. Any change, any abnormality prompts them to come back in. If you come in with the GCS less than 15 and you're after the event, or your CT scan is abnormal in the way of bleed or edema, you need to be observed because your risk of transformation into needing neurosurgery is really high. But most concussions don't require neurosurgery. They don't even require observation in the hospital as long as their GCS is 15 and their CT scan is normal. Diffuse axonal injury will have a very classic presentation. You won't miss it, especially in the vignettes on the boards. The patient must have angular trauma. They have to spin. And the way this is going to work is someone's in their car going really fast, and all of a sudden someone clips them on the side, and their car goes out of control, and they spin a lot. Angular trauma, loss of consciousness, no recovery into a coma. This is diffuse axonal injury. The diagnosis is made with brain imaging. You can see it on a CT scan. The MRI is better. What you're looking for is gray-white blurring. If you see gray-white blurring, your diagnosis is done. They've got diffuse axonal injury. They're basically dead. The treatment is worse, and then the acute subdural. You basically can only pray. Yeah, you can try to decrease intracranial pressure, but they have such damage done to their brain that they're probably just going to die. So in head trauma, what you're looking for is a basilar skull fracture that tells you, hey, there's more underneath. Epidural has the lens-shaped hematoma, craniotomy, walk, talk, and die. Acute subdural has a crescent-shaped hematoma. Young person, severe trauma, they're screwed. You can do what you can, but chances are they're not going to make it. Chronic subdural, elderly person with an old trauma now has headache or dementia. Same crescent-shaped lesion, but craniotomy or removal of that hematoma reverses the disease. Concussion, loss of consciousness with amnesia, normal CT, send them home if their GCS is 15 and their CT scan's normal. And then diffuse axonal injury, recognize the angular trauma leading to the dismal prognosis. That's head trauma.